Ladies and gentlemen, it gives me great pleasure to present to you Professor Ali Moussani, who will speak to us about bronchoscopic lung volume reduction surgery.
Good morning. Assalamu alaikum. My name is Ali Moussani. I'm an interventional pulmonologist and professor of medicine and surgery at the University of Rotterdam, Denmark. I'm very pleased to speak with you all on bronchoscopic lung volume reduction. I'm sorry I can't be there, but I always miss visiting Egypt, and I'll be waiting for my next chance to visit and see you all in person. These are my disclosures, and none of them is relevant to this talk or this topic. Today we will try to discuss some pathophysiology of COPD and treatment options available in this day and age. We will focus on bronchoscopic lung reduction, its clinical implications, the data supporting it, and the quick acceptance of this modality in international guidelines. And then in the end, we will talk briefly about what is the best way to select patients and develop your own programs in your own institutions. We have developed one very successful program at the University of Colorado. We've been treating patients for the last couple of years. I will start by discussing one of our patients, and we will use this as an example of how things are done. This was a 66-year-old woman with FEV1 of 27% and TLC, which is total lung capacity of 12%, and DLC of 44, RV of 191, ratio of 70%, 600 walk was 158 meters. Her echo showed right ventricular systolic pressure of 35 to 40. Excluding pulmonary hypertension, CT showed no contraindication to procedures such as bronchiectasis or Willis disease. She had quit smoking a long time ago, and she has some COPD exacerbation every year, and her last one was about 1 year ago. Now that case in mind, we will discuss some of the facts about COPD and how it is managed, and then talk about how this patient was managed and how generally we manage these patients, and then the outcomes. So, as you all know, COPD is a very complicated and a very common disease. It's the third leading cause of death in the U.S., and it is associated with a very big price tag of almost $49 billion in just medical costs, and it is a disease that is just as bad, if not worse, than advanced lung cancer. So, in severe emphysema, where FEV1 is less than 50%, represent almost 9.5 to 10% of the patients, which is at least 15 million patients in the U.S. alone. So, large number, severe disease, and high morbidity and mortality. And as the disease progresses from just simple hyperinflation, shortness of breath, to more severe disease with lower FEV1s and lower diffusions and higher RVs and TLCs, the patient's quality of life and level of activity declines with it. So patients have less activities, less exercise, and overall deconditioning of their muscles and body, and eventually they are restricted to their rooms, unable to go out or do even basic chores of their lives, such as grocery, and then they are basically hooked to their oxygen and have very high mortality and morbidity. As I mentioned earlier, the severity of the disease in severe asthma, severe COPD patients is comparable to advanced lung cancer. This is a publication which compared the symptoms different symptoms such as functioning, body pain, general health, anxiety, and then depression and mental health in patients with non-small cell cancer of the lung and the severe COPD. And as you see in this forest plot, that the patients with severe COPD are very similar, in many cases worse than patients with non-small cell cancer. The other things that you probably all know that as the hyperinflation gets worse with COPD, it becomes one of the predominant marker of higher mortality. And this is the curve that shows you that as the hyperinflation, or ICTLC ratio, drops, the mortality increases dramatically. And then it also entails the worst quality of life. These patients have low oxygen, low BMI, baseline increased dyspnea, and then further complications such as cardiac and circulatory problems. And the hyperinflation is really one of the cardinal features of this disease. And you can see that on day-to-day life, on their PFTs, and on their X-rays. So this is a patient with normal PLC and normal inspiratory capacity in FRC, and this is a patient with COPD with very high PLC, very high FRC, and low IC or inspiratory capacity. So this hyperinflation really is a primary problem in these patients, leading to lots of other downstream complications. Emphysema comes in sort of two flavors. The most common one is the homogeneous emphysema, which affects all different lobes of the lung equally. And then the other is heterogeneous emphysema, which affects predominantly the upper parts. Unfortunately, homogeneous is more common, which is often more difficult to treat, especially with minimally invasive approaches or even surgical approaches. You all know about the NET trial, which really laid the foundation for the bronchoscopic surgical lung volume reduction. The NET trial was one of the landmark studies which showed that patients who have upper lobe predominant emphysema and low exercise tolerance are the ones who benefit the best mortality and quality of life benefits when they undergo surgical lung volume reduction. And then on the other end of the spectrum, patients who have diffuse emphysema, which I just mentioned, two-thirds of them have homogeneous emphysema and have high exercise tolerance, are the patients who have the least benefit and perhaps much higher risk of complications. So this is really one of the basic things we learn from the NET trial. Now, what are the different treatment options now? We have oxygen therapy, steroids, bronchodilators, short-acting, long-acting, and all sorts of inhaled and nebulized therapies. Then we have pulmonary rehabilitation, which is shown to be very effective in terms of quality of life of the patients. And then we have three sort of invasive or minimally invasive approaches, which are bronchial valves, such as FR valves, and we will talk about today, or respiration valves. The other are surgery, bronchoscopic lung volume, not bronchoscopic, surgical lung volume reduction surgery, and lung transplantation. So, in our patient, the medical treatment was not enough. She was still very symptomatic, oxygen dependent, very low exercise tolerance, and basically restricted to her room. So we thought about all these three options, and obviously most of the patients choose to have minimally invasive approach first, and they keep the other two approaches, such as surgical lung volume reduction and transplant, for the later time. So we did then proceed with the workup and evaluation for bronchoscopic lung reduction. One of the early things that you do after looking at the CTs and PFTs, you do the evaluation. It's called STRATEX, or basically the evaluation analysis of the CT scan to figure out where the most emphysema is, if the fissures are intact or not, and also what will be your target lobe. So based on this report, you can see the emphysema score is highest in the right upper lobe, which is more than 70%. And the middle lobe doesn't have very severe emphysema. It is, you can look here, the right lung, and then this is the fissure integrity. This is the lung emphysema score on 2 different scales. This is the 910 voxel density scale, and this is the 950 voxel density scale. So on 910, the right upper lobe is 72% emphysema, and the right middle lobe is 41, and then the right lower lobe is 50. Fissure integrity is very important to look at and make sure patients don't have any collateral ventilation, because that if there is a severe collateral ventilation, your procedure will be rendered useless, because you will block the airways with the valves, but there will be backdoor channels for air going in and out in that lobe that you're trying to collapse. And that lobe will not collapse, and your procedure will not work. So that's why we first make sure that the fissures are intact. And then we, as we'll discuss later, again, before starting the procedure or putting valves, we do a collateral ventilation evaluation. The chart is below, and we'll show you that. So in this case, the fissure between the right upper and middle doesn't look very good. As you can see, it's less than 80%, and as you can see, it's only 62%. But the fissure between the upper and middle versus the lower lobe is pretty decent. It's about 92%. So what it is suggesting here is that we might have to also block the middle lobe. But middle lobe is very small, has very small volumes. You can see the middle lobe is only 500 cc's, whereas the right upper lobe is 1200 cc's. So it's literally less than half. And when we combine both of them, the emphysema score still remains very high. And fortunately, the fissure here is very strong, so we may be able to block both right upper and middle lobe. In a very late term, which may not be very well justified, you can think of this as a sacrificing middle lobe in order to get a major impact by blocking of the upper lobe. Since the fissure between the upper and middle is not good, and if you just try to block the upper, middle, and upper lobe will have collateral ventilation. On the left side, you can see that the left upper lobe's emphysema score is not very good. It's 51, and the lower lobe is 37, and the fissure is 73. So all of them are not very conducive for bronchoscopic lung reduction, neither the emphysema scores on the left upper lobe nor the fissure. So our primary and perhaps the only target in this patient would be the combination of right upper lobe and right middle lobe occlusion with the valves. As you know, valves are not the only way of causing bronchoscopic or achieving bronchoscopic lung reduction. There have been multiple different products in the market, which some of them have come and gone, some of them have failed in clinical trials. So far, the two types of valves are the most common and most comprehensive way of achieving bronchoscopic lung reduction. And the valves are the only modality that is approved in the U.S. But just to quickly review the history, there were two types of products. One for heterogeneous or predominant emphysema, the other was homogeneous or diffuse emphysema. The heterogeneous emphysema initially was treated with plugs and blockers, Watanabe spigots. sealants and biologics, valves, as I mentioned, aspiration and Zephyr valves, and coils. And then for homogeneous, there was an air bypass procedure called bypass procedure, and the study was called Axial, which failed and never got approval in the U.S. and the other studies by creating different pathways or airways. The basic concept of the bronchoscopic lung conduction is you choose the most affected lobe, and then you, instead of surgically removing it, which is what is done in surgical lung conduction, you block the airways leading to those areas or that lobe. And these valves are one-way valves which prevent air from going into that lobe, but allow air to slowly come out of those lobes. As a result, the air is redirected to the healthier lobes, as the diagram shows here. And as the air is redirected, the blood is also redirected, because wherever the oxygen goes, blood goes. And then you have a relatively better VQ matching in those healthier parts of the lung. And also because you have collapsed the affected lobes, the relatively healthier lobes now will have more space to expand and function better. Two types of valves, as I mentioned, one is Zephyr, which is the more common one, which is what we use for the most part, and aspiration valves, which have been around for a long time too. And then the structure of the valve, as you can see, there is this sort of metal frame, and then there's a ductile valve here which allows air to come out but not go into the lobe. The aspiration valves have these little sharp edges which kind of bury into the airway mucosa and prevent it from migration. And these Zephyr valves, they also have sort of very pointy edges here in the shoulders or in the body, which holds the valves in place very, very well. So migration is a very uncommon thing. And the procedure is done with flexible bronchoscopy under general anesthesia, and after you have done the collateral ventilation evaluation with charged balloons, I'll show you. But the valves are loaded into the flexible bronchoscope in a catheter and deployed in the airways. It is a relatively simple procedure. And as I mentioned, air can not go in, but secretion air can come out. Which slowly collapses the lobe. You can place as many valves as required to block off a lobe. Generally, we use somewhere between 3 to 6 or 7 valves, and eventually we collapse that lobe. So, as I mentioned, that trial was a major trial which laid the foundation for these modalities. And since then, there have been multiple trials, clinical studies, international and national, starting from Venn trial in 2010 to these more recent trials in 2018, the Liberate trial. Some of these trials predominantly focused on the upper lobe predominant emphysema. But these two, bilevel and the Venn trial, looked at the both upper and lower lobe emphysema, so for diffuse emphysema. Actually, all of them focused on upper and lower lobe treatments, but some of them initially did not have collateral ventilation evaluation, but later studies from 2015, Stelvizio, Transform, and Liberate used the collateral ventilation evaluation. Most of these studies were for heterogeneous emphysema, but IMPACT was predominantly a homogeneous or solely homogeneous patients to show that it is also very effective in patients with diffuse or homogeneous emphysema. Stelvio was both homogeneous and heterogeneous. But the point here is very thorough clinical background with studies covering both heterogeneous and homogeneous prospective randomized clinical trials with and without Chartis evaluation. And as I mentioned earlier, the concept of collateral ventilation is very, very important in this treatment. The collateral ventilation happens across the fissures, and if the fissures are damaged, no matter how you block off the airway, the air will continue to leak through the collaterals from one lobe to the other, and it will render your procedure useless. So what we do is called Chartis balloon evaluation, and Chartis balloon is inflated inside the airway, and it measures all the air coming out over the next few minutes and tells you that air coming out has now decreased or stopped. If it doesn't, and it continues, that means there is some backdoor channel for the air to get in. So here is
the Pulmonx Chartis system provides precise pulmonary flow pressure readings, allowing physicians to assess.
So here is the Chartis evaluation. We have a balloon in the airway, and in the middle of this is a catheter. All the air, the balloon is blocking any air from going in, while the catheter is receiving all the air coming out, and it's going into the machine. The machine is slowly seeing that the air coming out is slowing down, or it's less and less, and it shows you the amount of air, what percentage has come out, the total amount of air that has come out, and the volume, as I mentioned earlier. So you're seeing that since there's no air going in, and there is no backdoor way of air going in, the air is slowly reduced, and it's coming out less and less because the lung is basically now devoid of any air or slowly collapsing. So once the air or tidal volume coming out goes below around 6 or so, it basically shows to you that there's no more collateral, there's no more air left in the lung, and there's no collateral ventilation. If there was a collateral ventilation, the amount of air coming out will stay up, would never go down. Here you saw this number is now down to 9. It was earlier in 40s and 50s. You will also see that the amount of air coming out is less and less. The time it's taken about a minute and 23-24 seconds for the air to come out, and the volume coming out is less. So this is how the Chartis system evaluation for collateral ventilation works, and we do it for every single case, and establish that there is no collateral ventilation. So there are lots of studies. So this study was a LIBERATE trial, which was one of the major trials, prospective, randomized, double-blind, blinded trial with 2-to-1 randomization at 24 sites internationally. And the inclusion-exclusion criteria was, as we will discuss in a minute, was primarily patients with low FEV1s, high TLC, high RV, and other minor and other exclusion criteria that we will discuss were bronchiectasis, etc. The primary outcome was to look at the improvement in FEV1 after procedure of 15% in 12 months. And secondary endpoints included quality of life measures such as St. George's questionnaire and 6-minute walk. So what we saw in this trial was that FEV1 over the first 45 days increased 15 or more %. And then even after 12 months, the FEV1 remained upwards of 10%. So very significant improvement in patients who received the EDVV valve compared to control patients who did not have valves. Similarly, the RV improved, which means it decreased about 600 cc's or so in the first 45 days, and even after 1 year, it was still more than 40 to 50, 400 to 500 mLs, which is about 0.4 to 0.5. The St. George questionnaire improvement, as you know, anything above 4 is considered clinically and statistically significant. In these patients, it was close to 10 in the beginning at 3 months, and at 12 months it was still close to 8. And then the 6-minute walk improved significantly, and then in some patients, it continued to improve because they started to develop their stamina and muscle strength. While in other patients who were not treated, it actually declined over time because their disease was getting worse and their overall quality of life was getting worse. So patients who got valves compared to patients who did not, or shim procedure, a 50% of patients had significant FEV1 improvement of 15%, and then close to 60% of the patients had FEV1 improved more than 12%. RV reduced to 60% or 61% of the patients significantly. Similarly, 6-minute walk, bone index, and total lung volume reduction happened in about 84% of patients. And these are the patient-reported outcomes in their sort of a 6-minute walk and other parameters. As you see that a large number of patients, 40%, improved walking distance by 25 meters, and all these are the functional impairment, activity domain, and SGRG, all of those improved in these patients from standard of care to Zephyr valves, to DART Zephyr valve, and the standard of care OSS-LU. Patients were keeping daily diaries, so FSUMS scores and intensity scores also decreased significantly in patients with Zephyr valves as opposed to standard of care procedure, and the effect lasted in this study for a month, so 52 weeks. As in any procedure, especially bronchoscopic procedure in severely ill patients with emphysema, there were complications. The most fearful complication was the pneumothorax, which happened in about 25 to 30 patients. And this pneumothorax happened in 26% of the patients, which is the highest I've seen among most of the studies. And then most of these happen in the first 45 days. And I'll show you a graph that it's actually even sooner, in the first couple of days. And then long-term, past 45 days, it happened in only about 6% of the patients. COPD exacerbation was seen in about 7 or 8%. In the beginning, and a little bit more after 45 days, which is really after 1.5 months of procedure, so it is probably not related to procedure. And then there's minor issues. That happened in 3% of the patients, and that happened in 0.8% of the patients after 46 days. But again, it's hard to say how many of those were directly related to the procedure. The pneumothorax, most of the times, happened in the first 3 to 4 days. So these are the day 0 of the procedure, and then the first 3 days, Monday to 3. You will see that the number of pneumothoraces went significantly down after the first 3 or 4 days. And most of these patients who had pneumothoraces in the first 3 or 4 days were either managed with chest tubes or chest tubes and valve removal. So chest tube is chest tube plus valve removal or RTC dark blue. These are just chest tube and light blue are the observation. Very few patients were observed. And it's conceivable that patients with severe COPD have pneumothorax. We don't want to take any chances. The point here is first 3 to 4 days are crucial, and that's precisely why we keep these patients hospitalized for first 3 or 4 days after the procedure to make sure that they do develop pneumothorax, which only happens in about 25-26% of the patients. We can quickly intervene. These are some of the other studies. Stelvio was a study of 84 patients with severe homogeneous and heterogeneous emphysema, and 68% of 68 patients confirmed as collateral ventilation negative after charges balloon and underwent the procedure. And you can see the results again. Their FEV1 improved significantly, and then in the EBV group, in 72% of the patients, the FEV1 improved 15%, totally improved, and then many of those it was above 15%. And then these patients crossed over, and after crossover, again, FEV1 improved significantly in the same patients who did not have any improvement or significant improvement when they were in control group. 6-minute walk improved. As you can see, up to somewhere between 100 to 200 meters in most of the patients, and then crossover group and SGRQ also improved. So the important point of this study was that it is critical to confirm that patients are CV negative, which gives you a very robust outcome. IMPACT study was 93 subjects with homogeneous emphysema mostly, and this is really an important study to show that these valves work in homogeneous emphysema as well. This is a randomized one-to-one study where primary endpoint of FEV1 improvement was reached in a large number of patients at 3 months. And here you can see that 6-minute walk also improved significantly, clinically and statistically in patients who had valve placed, which is the dark blue, and similarly FEV1, MMRC, SGRQ, and other parameters of RV and TLC improved in these patients. And so again, the point in this study was to show that these valves work very well in homogeneous emphysema as well. Excuse me. Transform study, 97 patients had heterogeneous emphysema, confirmed the charges balloon evaluation to be CV negative, and were randomized 2-to-1. Again, same parameters showing significant improvement in all the primary and secondary endpoints in heterogeneous emphysema patients as well. So, pretty strong track record with clinical trials, international, prospective, randomized, placebo-controlled, both homogeneous and heterogeneous. And these studies were published in very reputable journals because they were very thoroughly done, and the results were very impressive. LIBERATE study was a randomized controlled trial, just as others, Transform, IMPACT, and Stelvio. They were published in Blue Journals and New England Journal, showing very high success of procedure, starting from 84% to 90%, and medium to large size studies with very impressive outcomes. As a result of a very successful modality shown to improve quality of life and other parameters, the international community has accepted this modality for the management of severe emphysema with open arms. This is now This modality is now part of the GOLD initiative as a level 1 globally. In the UK, it is approved for intervention as a part of the treatment options. It is approved by the Netherlands National Health Institute or National Care Institute and German Respiratory Society. More than 20,000 people have been treated with this modality across the world, predominantly in Europe and the US. As far as how and what we do at the University of Colorado, we have a program called Emphysema Advanced Therapies, or EAT program. And it is a multidisciplinary program, so we have a meeting once a month where lung transplant surgeons, lung transplant pulmonologists, thoracic surgeons, COPD and emphysema experts, and interventional pulmonologists, which is a big group of people. We all sit down and discuss every single patient that has come through our clinics and is possibly a patient with severe emphysema looking for advanced management. And advanced management could be either bronchoscopic lung reduction, surgical lung reduction, or transplantation. We all discuss and debate and go over CTs and TFTs and discuss what is the best method to approach this patient. Very similar to lung cancer boards, where we decide whether the patient should get chemoradiation or surgery or all of the above. We have also very deliberately protocolized our care, and the protocol is sent to the critical care team, and we keep the patient in the hospital. Every step is laid out that the patient should have a pneumothorax kit by the bedside, X-ray should be done every morning. And if there is any suspicion of pneumothorax, we shouldn't wait for interventional radiology or somebody else to put the chest tube. Our critical care team puts a small pigtail catheter themselves, and we have a protocol for first several days. We give them steroids to prevent exacerbation of COPD. We admit everybody in the hospital for 3 to 4 nights. And they are kept in the step-down unit, which is one level below the critical care unit. The step-down unit allows for them to be taken care of by doctors 24/7, so there is always a doctor on duty. This is our patient. When we decided to place the valves in this patient, LC, we did the measurements. And I'll be first with the Chartis balloon evaluation, as I showed you earlier. Once the Chartis showed that there was no collateral ventilation, then we measured and placed the valves. So I just wanted to show you in real life how we place valves rather than just the cartoon that you saw earlier. So here is the valve placed in this patient. And so this valve is already there, and it's breathing. You can see as the air comes out, it opens up, and then when the exhalation is over and air tries to go in, it closes, so it prevents air from going in. So this is our patient's chest X-ray on the day before the procedure. Remember, we blocked off right upper lobe. And you can see the lung is very hyperinflated, diaphragm is flattened and pushed down. Once we place the valves, you can see the lung volume is less, diaphragm is up and nice. And then in 5 days, you can see the atelectasis of the right upper lobe, which had started on day 1, is now almost complete. So the right upper lobe is where it's completely atelectatic. The lung volume is reduced, and the right hemidiaphragm is way up, causing a significant lung volume reduction compared to the left lung. Here, the left and the right lung are same sizes almost, and here the right lung is significantly smaller. And on our 1-month follow-up, we still see that the atelectatic lung is there. Diaphragm is still up nicely. But the lower lobe has now taken up some space in the right upper lobe, which was left vacant by the upper lobe atelectasis. So it's sort of re-equilibrating with a relatively normal, healthier lung by removing the affected lung. And looking at our numbers, our FEV1 was 27 before BMVR, and 1 month later it was 47. Our TLC improved from 112 to 113. DLCO improved from 44 to 57. RV went down to 159. RV-TLCO reduced significantly. A 6-minute walk improved almost 90 meters. So very significant improvement in our parameters. So I think if done correctly, this is a very effective way of achieving bronchoscopic lung volume, effective way of achieving improvement in quality of life and other parameters in patients. It is obviously much less invasive than surgical lung volume reduction, and it does not preclude lung transplantation. Patients are still candidates for lung transplantation, but until then they will have a much better quality of life and they may buy some more time. So when medical therapy is not able to control all the symptoms and patients are meeting the criteria of lung volume reduction, then they should be considered for bronchoscopic and other advanced lung volume reduction techniques. So first confirm the diagnosis that patients have COPD, and inclusion and exclusion criteria from the studies, which usually FEV1 less than 50% or more than 20%. Make sure patients are not smoking or they have quit a couple of months at least. FEV1 as mentioned below 50, and they are symptomatic with the MMRC of 2 despite the medical therapy. And then these are some of the workup summary with 6-minute inclusion and exclusion criteria. So the BMI is, make sure they have emphysema, BMI is less than 35. They're not on very high doses of prednisone. They're not smoking, and their lung and their CT scans show emphysema and not very significant bullous disease or bronchiectasis. Their 6-minute walk should be somewhere between 100 to 500 meters. Pulmonary function test, FEV1 should be 15 to 45. Body RV should be 175 or above. We actually now take patients with 150 as shown in other studies, but usually 175. TLC more than 100. And then in heterogeneous and emphysema, RV should be more than 175, and more than 200, and it should be more than 200 in homogeneous emphysema. ABG should be done to rule out PCO2 of more than 50 because CO2 retention should be an issue. And hypoxemia should be no worse than 45 VO2. On CT, make sure they have no large nodules, bronchiectasis, and large bullas. Any bulla more than 1/3 of the lung is an exclusion. And then load up the CT in the StratX to look at the StratX report that I showed you. I often do a perfusion scan, actually almost always do now perfusion scans, but it's really important in patients with homogeneous emphysema. It allows you to see where the little perfusion is less. So those are the areas that you want to target. Echo should allow you to rule out pulmonary hypertension, and if you're having difficulty, then by all means do the right heart cath in these patients and make sure patients have severe congestive heart failure. So that's all for now, and I'll be happy to take any questions via email or via chat. Unfortunately, I'm not there to answer any questions. I am sending this as a recorded talk for you all. I really appreciate your time and attention. I hope you enjoyed the discussion, and I hope it allows you to consider this in your patients as an important advancement in the management of severe emphysema. Thank you very much. Masalam.